One of our awards that we're going to give out is our Chapter Achievement Award. So this award goes to the chapter who has excelled and persevered in 2017. And this chapter actually had 5 events in 2017, so I need to take some tips from them, and offered bursaries to CVAA and other conferences, and held an exam. So they have done great work, very inspiring, and that winner is the Winnipeg chapter. Congratulations. Do we have someone who can come up from the Winnipeg chapter? Andrea Spencer. Oh, there you are. Oh, lovely. Wait till Andrea gets here. I know you just want me, but just wait. Congratulations.
Oh, thank you. This is surprising. Thank you.
Oh, wow.
Thank you.
Way to go, Winnipeg. And if you're, the BD Awards, Winnipeg, something's happening in Winnipeg. We got to go drink the water there. Our next award that we wanted to do was the Conference Keener Award. So this was the first person to register for the CVAA conference. So the minute we went up, they were in there, and that is Shanda McDonald. Shanda, you keener. Way to go. And I'm going to do one door prize too, because those people earned it, but we like to give gifts to people who don't earn it at all. You just show up. So that sounds good to me. Karen, you want to go?
Kathy Underwood.
Kathy Underwood, not to be confused with Carrie Underwood. Kathy Underwood. Hello.
We can split it later.
And now I'll invite my lovely colleague Andrea from the board to come up and introduce our speakers.
Good afternoon. Today we will be hearing about IV push medications from Karen and Maureen. You will be able to see their bios. Thank you. So you can see Karen's bio on the board there. Personal tidbit about Karen that you might not know is that she had a business as a woman's health coach in allopathic and complementary medicine prior to nursing. She has worked in Florida, Germany, and Canada. She has 2 cats whom she loves very much. And okay. She likes one, not the other. And she is planning on completing her PhD as a project for retirement. So welcome to Karen. And Maureen is the next presenter whose bio is also up on the board. Maureen loves animals. Animals include dogs and horses, and she breeds and races thoroughbreds. Okay. So please welcome them. Thank you.
Oh, do I have to pull my, oh, very good. Thank you. Get myself started here. Oh, I can use the big green button. Oh, look at that, we got this way too. This is
I
fantastic.
know.
I feel like I'm at the big time. Okay. Can you hear me? Oh, good. All right. Our declaration, I have nothing to declare. Maureen is being sponsored by Fresenius Kabi, Canada. We're not going to disclose we're not going to talk about anything off-label. Will be controversial, but nothing off-label. Okay, our learning objectives are here, and really the key ones here that we really want to talk about risks associated with IV push medications in adult patients. Just to be clear, it is adults only that we're focusing on. and looking at our at-risk behaviors from us as a nursing community with regards to how we actually administer IV push meds. And because of that, and because it's very on trend, we are going to be speaking a lot about a fair amount about the opiate administration practices. We conducted a survey of critical care nurses in Canada. We're going to share those results, and then look at some ways that we can actually help to mitigate risk. And before we start, I wanted to make sure that we're all on the same page. We're going to use certain definitions that are from the ISMP, the Institute for Safe Medication Practices, from 2015. And so these are the definitions that we'll be using throughout our presentation. Okay. So to start with, part of our practice as nurses is that, you've heard sayings, and I know this morning the guy was talking about our two presenters early this morning, for those of us who were keen enough to get up at 7. We heard people talking about the way we've always done things, that we've always done it this way, this is just a standard practice, and really those are sacred cows. And sacred cows really give us permission, if I can use that in quotations, to actually continue to support normalize deviant behavior. And I don't mean like as in like deviant behavior. I'm talking about practices that we do in nursing. And things like routine vital signs. Like, why do we do them? But we do. We have to take that blood pressure every 4 hours or whatever, because that's what we've always done. I know that one hospital I worked at, where we actually eliminated doing vital signs, nurses were having anxiety attacks because they didn't know what to do without checking somebody's vital sign. But there's no evidence to support it. The ones in red, the diluting IV medications, using a 10 ml syringe for IV push medications through a CVAD. We're gonna talk about that, and those are really sacred cows. And our concern is that because this normalizes behavior, it's very, very difficult for us to change. I just have to click, don't I? This is cool. All right. So I read this article when we were getting prepared for this from Shastay that said, while much evidence has been placed on the improvement of infusion safety, and we have had lots and lots of focus on infusion safety, little published evidence or best practices are associated with IV push medications. Well, there is a number of recommendations and guidelines that have been written and published specifically around IV push medications. However, the uptake of these, our ability to actually adopt these into practice, has been very, very slow. Well, I know that a number of them there's nothing really specifically from Canada. These are all recognized and highly respected references. So it's CDC, INS standards, the Institute for Safe Medication Practice, the American Association for Nurse Anesthetists. These are really strong, robust guidelines that really have not been adopted. And we know that those haven't been adopted because when we look at the Joint Commission resource survey in 2017, surveyed a lot of nurses to find out what they actually do for their IV medication practice. And so their top resources and references to either dilute or not dilute was really based on, as you can see, pharmacy, providing them with information, the manufacturer's guidelines, so just basically like 60%, hospital procedure, 50%, asking your nursing colleague, and then just basically doing it on your own. The other piece to this, when we're looking at preparing injectables, this is something where, again, when we look at that, it's really, there's no consistency in what people are doing with regards to preparing injections. And what we found in our survey and also in the literature is that the inconsistencies are even greater within an organization than between organizations, which is actually quite scary. And again, it's because, where do you go for the information? Well, I'll go to my colleague, or I'll go here, and so everybody's telling them something different. And that increases patient risk, and it is a safety issue. So when we look at IV push medications, it's interesting that this fact here, errors with injectable medications are higher than any other form of medication. That's all forms of medication administration. So your IV medications are your highest. which we found quite interesting because you would think that oral or something would be more, but it isn't. The next one here, fact that half of all harmful medication errors originate during administration phase. So how are we actually administering the medication? So that's 50% of the errors are because of administration errors. And then 2/3 of these harmful errors are specifically injectable meds. So these are pretty alarming statistics that we have to be thinking about, specifically for IV push medication. So what are some of the contributing factors? The ones in red are the ones that nurses can actually influence and change, but you can see there's a whole lot of these. And I'm going to focus on the red ones because that's the ones that we can influence, and we're going to talk about more today. So non-standardized practices and lack of training. As that quote I said earlier, there really is not very clear, specific guidelines for how to do IV administration or IV push medications. If we were to do a poll today, I'm sure we would get some really interesting statistics. Use of a part of a vial or ampule or more than one vial or ampule for a single dose. So rather than having the medication prepared in a way that we could go ahead and administer it, you're having to drop stuff from a vial or from an ampule or multiple vials or ampules. How you handle that, how you do that practice, are we following USP 797 guidelines? It's not just for pharmacy, it's for anyone who gives medication or administers a medication. Are we following those? No, we're not. The Royal we are not. And then, of course, preparing the preparation of drugs outside the pharmacy. There's limited or sometimes absent labeling of the product, and we'll talk about that in more detail. And, of course, actually administering or preparing under non-compliant or non-ideal conditions. So, in the community where I work, we have clinics, and they wanted us to start to admix this medication. And so we have this lovely medication area that is literally about the size of this. And we have a sink here, and this is our little countertop. Completely against the standard for preparing medications next to a sink. And plus, it's right next to a patient bed. So, it's really not according to standards. But these are things that we can actually look at and influence. And there's other factors that we're going to get into in more detail. So medication preparation, the labeling, as I said, ambiguous and undefined terminology or language. The labeling and language are so critical, and there's so many inconsistencies within Canada. The risk of contamination. We've talked about reducing CLAPSI for our patients, but IV medication administration hasn't really been on the forefront of that. And it's a huge risk for contamination. And then, of course, dilution and diversion. So the Joint Commission survey from medication preparation, which I found quite fascinating, 71% of the nurses reported that they do additional manipulations of the medications that they get from the pharmacy or are ready to administer. So this is something that's either been prepared by the pharmacy or comes in a syringe, but yet 70% of the nurses are still doing other things to the medication before they administer it. Their top reasons are because, it comes from the pharmacy that requires manipulation, which is interesting. So the pharmacy is just sending it up, but they don't have the right dose. The nurses perceive it as a short stability, so therefore they want to give it in a different way. The whole issue of cost. Is it too costly or too expensive to have something that is prepared ahead of time so that the nurse can just go ahead and administer it? It's actually cheaper if we just send it up to the nurse and the nurse prepares it themselves and then they give it to the patient. Is it really truly that much more cost effective? And we'll challenge that and say no. They're waiting too long for the pharmacy, so I'll just handle it myself and take care of it so I can give this to the patient, rather than following the processes that are in place. And of course, the one that was an example which we said, really, is this a reason why you're manipulating medications? Is because you don't have enough space in your medication cart. But nonetheless, these were the top 5 reasons why nurses manipulate medications. So then when we look at this, as you can see, close to 90% of all the patients of the nurses, not patients, the nurses dilute medications before giving them. That's a really high number. All right, and do all those medications need to be diluted? And we're going to say no. Okay. So the more the medication is manipulated before administration, the higher risk of contamination. It's just very similar to when we're saying we don't want to access a catheter unless we absolutely have to decrease the risk of contamination. It's the same principle. When we look at things like, so the real ones, this one here, Maureen's going to talk about a little bit more, but if you notice, 97% drop the medication into a syringe. Okay, again, a further manipulation of the medication. And then preparing the IV solution. So this is the medication coming up from pharmacy and the nurse is having to admix it. And then I keep forgetting this is here. Okay, and then, and then having to admix it and then calculate the medication yourself by calculating how much you want to put into a syringe to give to a patient, which is huge risk. So not only are you manipulating the drug, you're manipulating the dosage that you're giving and also increasing your risk of contamination. So not really good. And so when we look at one of them that we talked about was labeling. It's interesting. I've been in and out of the hospital for the last 3 months, and the people that I was visiting required medications, and so every nurse that came in, this was not just a one time, but every nurse that was coming in giving pain medication to my family member came in with a syringe that looked very similar to this. It was unlabeled. They came in with the medication. They were coming from the medication room, walking down the hall with their unlabeled medications in their syringe and their flush solution, and bringing it into the patient, into the room, and then giving it to him. And of course I asked them, because of course I'm getting ready for this presentation, I'm going, well, don't you label the syringe? Well, why do I need to? I'm carrying it here. So what would happen if something happened and you got distracted? Oh, that's not going to happen. Last I checked, when I was in the hospital, it is something that can happen, but I mean, that's a risk, and that's against any of the standards. The other thing is that, so we have this one here where we have no idea what that is. Okay, it's just midazolam, but we don't know how much it is. We don't know when it was prepared. It's just, we know that what's supposedly in the syringe is that. This is my favorite. I really like this one. Okay, I'm not sure why they chose to put that over instead of a cap, but we're going to give that to somebody's CVAD, I'm sure. It's really good, yes. So this is a problem, right? Like the standard is to label the syringe with the name of the medication, the amount per mil, the person that drew it up, the date and the time, so that you know what's going on, but that's not happening. So, you know, again, the thing is that improper labeling for medications prepared outside the pharmacy was consistently identified by the ISMP as one of the highest risk behaviors. This is an example of how, whoops, sorry, wrong one. Oh, it worked, good. So this is an example of how you want the syringe to be labeled. As you can see, it's dilaudid, 0.2 milligrams per mil, and the person's name and the date and the signature. This is a standard of practice that is not being followed in a number of places. So it is a very high risk because, and we're going to talk about that, because not only is it that you don't know what's in there, but it also helps to contribute to diversion. So we're basically supporting at-risk behavior. The other thing, so for risk mitigation, these are some options that you can use. Of course, this is an example here and right here, which is a pharmacy prepared medication. It tells you what the medication is, how to administer it, and all that good stuff. And this one even has a barcode on it. How many people have barcoded medication administration here? Oh, great, awesome. You notice, I think there were 3 of you. So at least that's good. And then of course we have the ready to administer medications, or what we call pre-filled syringes. That's a really nice one. This one here has a pre-printed label. So this comes up from the pharmacy. The nurse has to mix it before giving it, but at least that way you have a pre-printed label that you know what you have to put in there, rather than just taking a piece of tape and writing on it and putting it on the bag, or just a blank label so you're trying to remember what you need to put on there. And so this is a good example of this is what I call the Goldilocks. So this is definitely not right. They're on the way there, and this is just right. Okay. Language. So how many people use the term IV push for medication that is to be given undiluted within under 2 minutes? 1, 2, okay, just a few of you. Okay, how many use the term IV bolus? Okay. How many see IV over X number of minutes? Some, okay. Slow IV push, it's one of my favorites. Like, they're all used interchangeably for giving IV push medications. So this inconsistency, this unstandardized verbiage is really a risk. I mean, like, how would you even know? Like, you don't know what to give it. For a lot of places, they don't have policies or procedures in place to define what IV slow push means. We have doctors writing all kinds of things, and all kinds of ways to give medication, and then it's left for the pharmacist or the nurse to interpret what that means. Really, I would not know how to interpret IV slow push. Didn't see that when I was in ICU. We just said give it IV, and then the nurse decided what that was based on the pharmacy formulary and standards that were for the hospital. But there's a lot of inconsistencies that are really making it difficult. And there's no standards as far as language in our profession as well. So the guidelines are working on that. There we go. So there's a need for clarity and also need for standardization of those terms across the profession and at least within your organization. I'm sure that, like in some of the survey in critical care, what nurses in critical care do versus what the nurses do on other floors is very different. And again, that inconsistency is a safety risk. So the ISMP recommendation is they define IV push as direct manual administration of a medication using a syringe. So it may or may not be a bolus, and then they define the bolus, which means that it's a distinct dose of medication given rapidly over a short period of time. Okay, so we're defining and differentiating between bolus and IV push. And further to expand on that, the policies and procedures, the processes and the institution would define what that short period of time is, or it would be based on what the manufacturer's recommended administration dose is. So we talked about risk of contamination because we've talked about medication preparation, labeling, and prepping. Again, I just want to reinforce that every time we manipulate a medication in a ready-made syringe or in any other vial, we're increasing the risk of contamination and therefore risk of infection. This is a position statement from the APEC, which is the Association for Professionals in Infection Control, and they've reviewed this. They started this in 2010 and reviewed it, and they're still holding firm to this, that this is the transmission continues to occur due to improper injection, infusion, and medication practices. And all of those standards and recommendations that I had listed earlier are very consistent with this as well. So the thing is that what we have known, there was an incident that happened early in 2017 where one hospital had a run of patients developing hepatitis C because nurses were diverting, there was a couple of nurses that were diverting medication, opioids, and what was happening is that they contaminated the patients with the syringe, and so they developed hep C. The other thing that can happen is that if you have, you can get these weird and wonky bacterial infections, and if you have a couple of those that you know are out of the norm, you need to be suspecting that somebody has been tampering with the medication, with the administration. So I think it's really important that along with personal protection, along with all kinds of other examples that we've looked at for risk mitigation, which is, of course, our caps and tips, our scrubbing the hub, our making sure that we have the one and only injection. I'm not sure how many people are familiar with the CDC program, one and only. So it's one syringe, one patient, one time. Okay, I observed that that doesn't happen in the hospitals that I've been at for the last couple of months, that nurses are using the syringe, flushing the line, taking the syringe out, putting it on the bed, no cap, giving the medication, taking the same syringe, putting it back in, and et cetera. Yeah, I know it's horrible, and I'm like going, oh my gosh. I wrote a little letter or two, I have to say, while I was in that, yeah. So in my spare time, I wrote a little letter or two. Oh my gosh. Of course, our hand hygiene. So what's missing on this page? Medication administration, right? Reduction of medication manipulation so that we can make sure that we're not increasing the risk of contamination. So that's something to think about, kind of, like the whole area of IV push medications and really giving IV medications has really been a long haul because there has been a lot of inconsistencies. And there's a lot of risk for that. And so because of that, we're going to spend some time looking at the dilution dilemma. And so I'm going to give this over to Maureen, who's going to talk about specifically about dilution.
Thank
Her
you,
favorite
Karen.
topic.
My favorite topic. I'm going to try to, can you guys hear me? Okay, I'm going to let this one drop down because I use my hands a lot when I talk, so I'm a little bit better if I don't use it. So if you might have noticed on my bio, before I started doing this kind of work, I was working as like the vice president over quality and safety and risk, and it's like you have to be, a mile wide and an inch deep on things. And since becoming part of a medication management consulting company, it's been really great because I get to be an inch wide and a mile deep. And my passion has been around IV push medications. So dilution has been one of these things that, from my point of view, I grew up as a critical care nurse. How many people here were critical care nurses? Awesome. And how many of us ever diluted drugs that we gave IV push? Not as many. And there's a lot of reasons for why we do that. But we started looking at dilution with IV push as whether or not it was needed because there's a lot of risks that are involved with it. So I'm going to throw this out to you and just basically say there is no evidence for dilution of IV push medications. As Karen mentioned, this is one of these things that we look at maybe as a sacred cow. It's something that we've sort of grown up with and it's evolved over time. I've been a nurse for a long time. I had my 40th class reunion last summer, and I've earned every one of these silver hairs. And thank you. I'm not sure I even thought I'd live that long, but it happened. And, when I first started working in nursing, it was the early age of ICUs, and even before that, I started looking at the history of IV push medications because it's kind of like, how has it been evolving over time? And honestly, back in the 50s and the 60s, the only job that the nurses did is we pulled up the medication in a syringe and we gave it to a doctor to administer, whether it was an IM or an IV. But as we developed critical care units, nurses started they were giving the IMs, and then because we couldn't give intramuscular to really sick patients, we had to start giving things intravenously. So we began to develop sort of the art of giving intravenous medications. And I'll say the art because we think of nursing as the art and the science. But we used it sort of from the art. This is the way I like to do it. As time went on, we started giving more and more medications, more preference as intravenous. So remember, some of us grew up giving Demerol and Vistaril intramuscularly for pain medications. You wouldn't find anybody doing that now, but nobody gives IM medications hardly anymore. Everybody gets IV medications. We give IV pain meds, we give IV antiemetics. We have a lot of new drugs that we didn't have a long time ago. So IV medications have moved from out of the ICUs, and now they're in almost just about every other setting. And the other big thing that's changed is that we do DVT prophylaxis, right? So we have a lot of people either on chemical or mechanical prophylaxis, and not many of us want to give an IM injection to somebody who's on enoxaparin or heparin, right? So we've been growing this evolving sort of world of IV push medications, and I'm not sure that we as nurses, if we've fully developed the science around what we're doing, and it might be time for us to take a look at our practices. I will say this though, there is evidence against dilution. So we're going to talk a little bit about that today because I think that we think that we're doing the right thing, but we may not understand that there are unintended consequences. So back in about 2015, the ISMP did a survey of nursing practices in the US, and they had almost 1,200 nurses who responded, and these were some interesting findings. They found that, so this is self-reported stuff, which is different from observations, but self-reported technically is a little bit under what people are actually doing. So in this case, 83% of people said that they diluted IV push meds. That was pretty astounding. And 50% of them would dilute multi-dose vials and or pre-filled syringes. Now in the US, we have something called CarpEject. Some of you may, if you've ever practiced in the US, you may have run across the CarpEject. It's like a cartridge that fits into a holder, and people use it like a skinny vial a lot of times in the US. Simplest is something that's newer, but it's another pre-filled manufactured syringe. And we're finding out that people were taking these things that were manufactured, pre-filled, beautiful, sterile products, and then transferring them into another syringe and further manipulating them because they thought it was a good thing to do. Even pharmacy prepared syringes, they were taking them and then further diluting them. We also found out that in this survey, about 46% of the people were diluting opiates, about 50% were diluting anti-anxiety and antipsychotic drugs. Now, of interest there's one drug here that is required to be diluted, so that's Ativan. So if you only 50% of you are diluting it, we actually had 50% who may not be doing that correctly because it should have been 100% if it's Ativan. And then 33% were diluting antiemetics, and very few antiemetics actually require that if they're at just a regular dose. 20% were diluting cardiovascular drugs, things like digoxin. Not diluted often, insulin, heparin, Narcan. So it was very telling that there were a lot of different practices going on. So then they asked, well, why were the reasons that people were diluting? So with my little quality and risk hat on, I consider that like getting at the root causes. What are the root causes why nurses are diluting? So one of the reasons is anticipated discomfort at the injection site during injection. So in our minds, we are trying to help prevent a problem from happening. And we do know that patients do experience sensations when we give them IV push medications. Whether it's pain or not might be debatable, but there's clearly, you can give somebody saline flush and they're going to feel it. Another reason that people will dilute is if it's a drug that's a vesicant or an irritant nature. Now, most of us know that drugs that are known to be vesicants or irritants, and I'll just say most of those drugs, tend to be prepared by pharmacy or they're in very specific settings. But we have found that there's a lot of people who don't know which drugs can be dangerous in that way. So they just consider all of them to be, which, I think we're better than that. I think that we should know a little more about the drugs we're giving. Sometimes there's a risk of extravasation if the medication or the drug delivery device is suspect. For instance, if we're using a butterfly to give drugs through, occasionally that can be something where I'm going to be really concerned about whether or not my drug might extravasate and cause problems. So in nurses' minds, this is one of the reasons why they were choosing to dilute. If you need to give your drug very slowly, nurses are saying, I have to give this drug really slowly because if I don't, this patient's going to have a significant adverse event. And I always remember back to the package insert for morphine, which will say morphine 2 to 15 milligrams IV, give over 4 to 5 minutes. And I'm just going to scratch my head and say, I have no idea how fast to give that drug because of the ambiguous directions that are given with it. And would I give 2 milligrams over 5 minutes, or would I even give 15 milligrams IV? So there's a lot of information, especially on legacy drugs, it's difficult for people to follow. And I will just say this idea of rapid administration causing adverse effects, can anybody here ever tell me if they've ever seen a patient experience speed shock? Thank you. I rest my case. It still shows up in literature that this is one of the things that everybody's supposed to be looking for. I will honestly tell you, I practiced for 35 years before I even heard the term speed shock. And I remember talking with one of your well-known colleagues, Lynn Hadaway, once, and she's like, we really got to get rid of that word because it doesn't happen. But it's still back in the people's heads. I'm sorry? Sacred cow. Kinda, yeah. And then if there's difficulty in measuring small doses of medication, people want to dilute it out so that they can get to a better dose. And we know that that's tough because some medications are very concentrated, and they were concentrated especially in volumes because we were giving them IM before, and now we've converted to giving them IV. But there's different ways to handle that, and we especially don't want to be having to do that kind of compounding at the bedside. Some other reasons why nurses dilute. So I think this is interesting. If I'm going to give a med through a peripheral IV versus a central IV, I have a tendency to dilute it more. That kind of makes sense if you think of the blood flow from a peripheral to a central. If I'm going to give it through a saline lock versus a running IV, I have a tendency to dilute it more often if it's a lock versus a running IV. And we could talk for another hour about what's the correct procedure for administering it if it's a running IV. If the prescriber wrote to dilute the drug, I'm probably going to dilute it. And then if it's recommended from the device or the pharmacy that it should be diluted, or hospital policy. We had a meeting a few months ago, and I asked all the people coming to this meeting to let us know what kinds of policies, what kinds of references they were using at their hospital to guide their practice. And they responded, a lot of times in the States, we use sort of like Mosby's or, Lippincott, and we buy the manual and we say, this is our procedure book. So a very accomplished nurse researcher from a university hospital was there, and she said, this is what we use. And I said, that's great. I said, do you know that in this manual it says that you're supposed to dilute these medications? Because she had just told me that they don't dilute them. I said, so really, you're not practicing according to your policy. So we buy these manuals and we think that they're giving us guidance, but we really don't know sometimes what they say. And then finally, one of the other things that we've noticed is as IV medications have moved out of the ICU and the ED and into med-surg areas and different places, there is, if you're really bored someday, go to askanurse.com. And it's like a nurse-to-nurse sort of advice column. And they have different, like have critical care group and a med-surg group and an ED group. The only group that talks about IV push medications actually is the med-surg group. Nobody else talks about it. It's sort of like it's a non-issue for other groups, but for med-surg, it's a big issue. And you think about it because of the nurse-patient ratios and it's an unmonitored setting, they're much more worried about what they're doing. So here's some of the reasons why med-surg nurses say they dilute. So with this one person said, well, it's just safer to dilute all the IV push meds because I don't know how the patient's going to respond. I still don't know what the relationship is between those. This nurse said, I can't remember which ones to dilute, so I'm just going to dilute them all. And this is advice they're giving to each other. Now, this is one that comes up, and this was even at the hospital that I had just previously been at. Our policy says we have to use a 10 ml syringe when we access a central line. So I dilute everything into a 10 ml flush syringe. Now, I know every single one of you in this room know the difference between flushing and administering a medication. And the guidelines that were published from the ISMP a couple of years ago clearly say, same thing as the INS guidelines, 10 ml diameter syringe when you're flushing, use the appropriate size syringe when you're administering a medication. But we work for hospitals that sometimes don't give us the benefit of the doubt that we know the difference. So they just say use a 10 ml syringe so that you can't make a mistake. But without understanding the risks that are inherent in manipulating medications. This is one I like. So I don't have the time to stand here and push it slow, so I'm just going to put it in a piggyback and drip it in. And I'll be honest, I'm guilty of doing that too. I used to work in a cardiovascular ICU, and we reverse our patients from their anesthetic. And when it'd be time to give them their reversal, I would just put it in a bag because I wanted to give it slow because I didn't want the bradycardia to happen. My friends, they would just push it because they said, they have a pacemaker, they'll turn that on. I didn't have time for that either, so. But we don't have the ability to make a change. If it's ordered IV push, it's really outside of our scope of practice to decide that we're going to put it into a mini bag. That's actually a prescribing piece. So it's a little bit of a risky practice. And then finally, I have no way of knowing if it'll hurt, so it's just best to dilute all IV push meds. So I'm going to tell you here that dilution is not needed for most injectable meds. So remember that the nurses said that they wanted to dilute everything because they were afraid of pain at the injection site. I would counter that by saying that pain versus sensation, and how do we communicate to people, what kind of sensation that they should experience, because any of you who've had an IV, and everybody raises their hands before that they all had IVs in a previous session I went to, and you've all had it flush and you've all had something giving it to it. Well, the first thing that happens is you have a temperature sensation change. Think of what your body temperature is and what's the ambient temperature in this room. there's got to be about a 25-degree Fahrenheit difference in that, and you're going to feel that. Your vein is going to feel that. You're going to feel that. If we don't explain that to patients ahead of time, they go like that. Ooh, is that pain or is it sensation? I don't know, but if I don't help them to interpret that sensation, it can be called pain. I also have to think about, how I'm delivering it. I have to think about, is there anything else in the assessment of that vein and that IV on that patient that may totally be unrelated to that drug that's being given. Another reason that you don't need to dilute is, most of these medications, unless it's very specific in the package insert, the prescribing information, based upon the pH and the osmolality of that medication, it is within normal limits and does not require dilution to change the chemical nature of it. Most of these drugs that we're giving IV push are also approved for intramuscular injection. So let's just think about that for a minute. If it's approved for intramuscular injection, would I give somebody an IM if it's going to destroy their tissue? So it's kind of a practical thing to think through. But I call them the fabulous 5. There are 5 drugs, right offhand, that we will have to have prepared at the bedside because of stability issues that cannot be prepared ahead of time and given to you by the pharmacy. Protonix, Pepcid, Ativan, Phenergan, and thyroid medication. There's only 5. All the rest of the medications that we're out there giving do not need to be diluted. And I had a conversation with, are you here today? Are you here? There's a young lady who did a poster presentation, and we were talking about some of the medications that had previously been coming up from the pharmacy in mini bags. And some of them were things like ondansetron, dexamethasone, diphenhydramine. And I asked what the doses were, because if it's ondansetron for, oncology-related nausea and vomiting, and you're giving 8 milligrams, 12, 16 milligrams, you would expect that to be in a mini bag because you don't want to have any kind of cardiovascular effects. But these were 4 milligram doses, in small doses that were typically given IV push. So we are if we take a look at the drugs themselves and what the indications are and what the correct doses are and what the PI say, many of these do not require to be diluted at all. I'm sorry, there you're sitting right there. Okay. So she's actually done a process improvement for her patients that is not just about using caps and tips, but actually improving the drug delivery for her patients by doing that, your project that you did. I'm sorry? Yeah. So, that's serendipity, right? So another thing about diluting IV push meds. So one of the best things that ever happened to all of us was the pre-filled saline syringe, right? I mean, this took care of fixing a really big problem in healthcare in terms of contaminated saline that was being administered to our patients and bloodstream infections that were occurring. But like every other good thing, there may be some unintended consequences. And one of the things that happened is when we introduced these into the hospitals, the vials of saline disappeared, right? So if you wanted to dilute a medication, you couldn't find a vial of saline anymore because we assumed, and I didn't know any different either, that the saline in the syringe was exactly what it was supposed to be. Surprisingly enough, they're not a drug, they're called a device, and they're not approved for reconstitution or dilution of medications. So it's kind of hard to put the genie back in the bottle sometimes because everyone's become very used to using them for dilution. But maybe we should look at how much we're diluting. So instead of trying to bring back a lot of vials, let's stop diluting medications. Now, Karen put the yikes on this, but the hands on this, if you go to YouTube, our colleagues in the College of Nursing at Ohio University, this is a training video from their nursing program. And this is an instructor showing them how to dilute medication into a pre-filled saline syringe. This is absolutely true. And this is the technique that I would use also, putting the needle in there. How many of us wear reading glasses? We can't see anything anymore. We have no depth perception. So that needle is going all over. Now, this is how these things become contaminated, okay? This is no joke. This is why it's time for us to move from art and go to science. That is a very good example of what I call normalization of deviance. We don't even understand that what we're doing anymore isn't right. And then finally, I'm going to just counter the argument about I have to dilute it in order to inject it slow. You know, first of all, there is a lack of evidence around rate of administration for many of the drugs that we're giving, which is why we see in many of the books, I think probably Gayhart's book is one of the most well-known books about IV push medications, and many of you are nodding your heads. If you read Gayhart's book, you'll see some different sort of recommendations in there. And Gayhart's perspective is everything should be diluted that's given IV push. And in fact, in her preface a few years ago, she had a comment, it's no longer there, but she had a comment that essentially said, hospitals are telling nurses not to dilute so they can save money on saline syringes. And that was really, I felt uncomfortable reading it because I thought there's a reason why we're trying to discourage people from diluting, and it has nothing to do with cost. It has to do with reducing the risk from manipulating medications. But when it comes to rate of administration, I had this aha moment one day. I was talking to a colleague about, how fast is fast enough, and she said, well, how fast does a PCA pump administer a bolus? Does anybody know how fast a PCA pump administers? What's the rate? I was really surprised. So I looked. I went to CareFusion and I went to the other pumps. And the base rate that is preset on those pumps is 250 mLs per minute. It's so I want you to just think about the value-added piece of me standing here for 4 minutes with 2 milligrams of morphine after my PCA pump just blasted that in, thinking, wait a minute here. So I think without doing a randomized controlled study, we probably have some opportunities even within our own practice to look and say, we already have some demonstrated safe practices. They're just not a nurse's hand that's doing it, and we're not having problems with our patients. But the other thing that's been interesting to me is if I spend the time diluting, let's say I'm going to give 0.5 milligrams of hydromorphone, and I take and I dilute that into a syringe to give, and I spend my time giving it slowly. Let's say I'm giving it in a running IV. I even shut the IV off because I'm going to be really good. I've cleared my injection port with saline. I'm now administering this, and I'm standing there and I'm giving it all the time in the world. How far do you think it went? With how much extension tubing's on that IV? And what's the fill volume in that? So even if I gave it, with 5 mLs of fluid, I haven't given most of my dose to that patient yet. But then I'm going to take and I'm going to follow behind it with another saline to clear my IV line. And here's what I do with that. Karen knows because she watched somebody do this when she was out with her friend. I slammed that saline in. So I've just defeated all my time I just spent slowly filling my IV tubing with the drug by pushing it in fast. So let's change that paradigm for a second. I'm kind of a lean thinker. I'm always looking for the non-value added steps and things. If I don't dilute, so let's say I'm going to give 0.5 milligrams of hydromorphine, that's about half an ml. I could flush, I'm going to use a saline lock for instance. That's a really good example. I flush my saline lock, I administer my 0.5 mLs, and my fill volume in that 6 inches of IV extension tubing is about 0.5 ml. And then I'm going to flush behind it, and I'm going to control that rate of administration with my flush. And that's actually one of the most important pieces I picked up from the consensus meeting that ISMP had, is that the rate of the flush is just as important as the rate of the medication. And given the fact that we now have extension sets on things, we should be reevaluating how we do that. And so that old, the SASH method or the SAS method, there is some utility in thinking about that procedure as a way to help control the rate of administration. And I think this is an opportunity for a group like yours and other groups to take and study that, because I think we could successfully avoid diluting a lot of medications by thinking through this procedure a little more. Now, one of the other things that we wanted to bring up has to do with how the dilution in diluting meds, especially opiates, may be playing a role in inadvertently with tampering and diversion of medications. And Karen referred to some infectious outbreaks that had occurred because of tampered injectable medications. How many of you have caught the W5 series that was done on drug diversion in healthcare? really, really interesting information. And when I'm not, out here talking about IV push medications, I do drug diversion risk assessments in hospitals. And one of the things that my colleague, I go out with a pharmacist and another group of people on the team, but what we've really begun to understand is that drug diversion is really related to two things. And so we kind of came up with a little catchy equation, but it's access and opportunity really lend itself to drug diversion. And when we are manipulating IV push medications, we are creating opportunities for people to tamper and divert. So when we were, Karen and I were thinking about practices of nurses and how they handle opiates, we had the opportunity to go to the Canadian Association of Critical Care Nurses last year in September. Great opportunity. We thought we just put some questions together. We kind of structured ourselves to do sort of a descriptive study using a survey technique. And not surprisingly, the meeting was in Toronto, so the majority of people that we interviewed were from Toronto. Most of them worked with adult patients. About 90% of them were from ICU/med-surg ICU, so kind of a diverse group. And the majority of them were staff nurses, so we were really getting a good cross-section of opinions about things. And the first thing that we asked them is we wanted to kind of find out what were the trends, what were they seeing as the most frequently prescribed opiate. And fentanyl is the number one opiate that's being prescribed in these ICUs, with hydromorphone second, and morphine is the least often prescribed. That's a shift. If you look over time, morphine used to be number one, then fentanyl, then hydromorph. So it's kind of changed, it's morphing. The morphs are morphing. And then from that, we said, okay, so if you're using morphine, let's ask you a few questions. And so the first thing we asked is, what was the dose that was most frequently prescribed? And they mostly talked about sort of range orders, but if it wasn't a range order, it was a 2 milligram dose. And if it was a 2 milligram dose, we asked them if they diluted it, like if they had a 2 milligram vial, because what you have available to you in Canada is different than what's available in the States. So in Canada, you have 10 milligrams and you have 2 milligrams. We have a whole lot of other product forms. But what we found is that very few times, even if the dose is frequently 2 milligrams or a range of orders, what's happening is the pharmacy is only giving you the 10 milligram vial to work with. So if they have a 2 milligram vial, they're not diluting it, they're using it, they draw it up and they give it. But if you're only given a 10 milligram vial, what we found out is that they're taking that 10 milligram vial and they're diluting it into a 10 ml pre-filled saline syringe. So you would say to yourself, well, that's nice, but then what do I do with the other 8? If I have to give a 2 milligram dose from a 10 milligram vial, what do I do with that other 8 milligrams? So what are you supposed to do with that? Do you think anybody's wasting it? It's exactly right. It's not being wasted. And that was a message that came through loud and clear to us, is that one person out of all 35 said, it's a patient safety issue, I have to waste it. And everyone else said, I know I'm not supposed to do it, but because of cost, I keep it. And that was a huge wake-up call. No, they're keeping it for 12 hours, and if they still have any left at the end of the shift, they give a report and they pass it to the next nurse. So, yeah, people were very honest with us when they gave us an idea of what their practices were. So basically, morphine is being provided in 10 milligram vials, even though it's a range dose or a 2 milligram dose, and people are preparing it in a 10 milligram syringe. For hydromorph, usually again a range dose, but after that is a 0.5 milligram dose, which we actually were very happy to see that. One thing also that's different is the prescribing information for hydromorph is different in Canada than it is in the US. And back in about 2011, we had, there was a lot of people that were having adverse events associated with confusion between morphine and hydromorph. I'm sure you're aware of that because hydromorph is 7 times stronger than morphine. So if I ordered 2 milligrams of morphine, and I confused it and ordered 2 milligrams of hydromorph, I basically just gave you 15 milligrams of morphine. So if you were short on morphine and we were exchanging it for hydromorph, we were having a lot of adverse events happen. So they collected all that information and they went back to the Federal Drug Administration, the Food and Drug Administration in the US, and they changed the prescribing information so that the initial dose for IV administration is now 0.5 to 1 milligram versus before it was up to 2 milligrams. It is not changed here in Canada. So hydromorph, people are diluting it and they're all putting it into 10 ml syringes. If the pharmacy prepares it, it's only for an infusion or a PCA. And then with fentanyl, again, mostly arrange orders followed by the 100 microgram dose. Interestingly, less dilution of fentanyl, and probably because the vial size or the ampule size is closer to the dose that is going to be given. Other findings, and this is where it got interesting. So we sort of had our surveys laid out, and then we asked people to just sort of tell us what they were doing. We found that there was no standard way for people in terms of a procedure. If I really need to do a bedside dilution of an IV push medication, there is no standard procedure for how that's being done. We found that there are still a lot of people who are decanting medications either from a vial or another syringe into the 10 ml syringe if they're giving it through a central venous access device. That their hospitals are not purchasing pre-printed labels for people, so a lot of people still just tape the vial to the syringe. And again, this saving partial doses for later use. And we totally understand the whole recovery room. You know, I'm giving aliquots and, you know, every 5 minutes I'm giving a dose, but this was not in a recovery setting. This is where I'm giving something every hour to every 2 hours. One other thing that we found, and this one caused us, we had to really think this one through. It's not unusual for hydromorphone to be given as a subcutaneous, injection, whether it's through hospice care, palliative care, and sometimes in an unmonitored setting, they might use it that way so that you have less risk of some of the side effects from the drug. What we weren't as familiar with, though, was the use of a butterfly, and you know how the butterfly's got the little piece of tubing on it. The butterfly was being primed with straight hydromorphone and then inserted, and then periodically they would come in and just inject the hydromorphone in and put fresh hydromorphone into the tubing. So essentially you're leaving a reservoir of hydromorphone in an unsecured situation. So I want you to think again from this morning when we were listening to Jocelyn and she was talking about 1 in 7 persons having substance use disorder, and these are our colleagues. This is the same pool of people that we hire, our nurses and everyone to work from. And we are maybe inadvertently making it easy for people to find and tamper with drugs because of some of our practices. Saving partial dose, this is another one too, and this is kind of counterintuitive for people, but fentanyl 250, 500 microgram large volume containers on nursing units because pharmacy's not available to make drips, but what nurses are doing are taking and making multi-dose syringes out of them and using them for the day. Now, it's one thing if you have a 100 microgram or 200 microgram fentanyl, but now you've got a 250, and if that isn't an invitation for somebody to swap that out, I don't know what is. Okay, real quick, because we're going to run out of time here. There are some recommendations from ISMP. Some of these have to do with not having high dose, high concentration of hydromorphone and morphine and fentanyl on your clinical areas so that they cannot be inadvertently used. You want to restrict as much of admixing, so nurses making drips as much as possible should get pushed back to the pharmacy to be doing that. And then standardizing as much as possible around your policies and practices. Lock boxes versus automatic dispensing unit, whichever way you secure your drugs, what you want to make sure is that they stay in secured storage as long as possible. And that when you take out a drug, it's going to be administered and then wasted, and then there's nothing left that's out of secured storage. What we heard loud and clear was, well, I tuck it over here in my room, or I hide it under here. And if I know that, everybody knows that. Or I lock it in the cupboard. The problem is that there's the same key for every cupboard in the unit. So anybody has the key. We also have to think about the fact that if we're doing any compounding at the bedside, we have rules that we have to follow as nurses. And nurses are still going to be held to the same standards as pharmacy will be from NAPRA. And the most that we could do is reduce the amount of compounding that we have to do and let it be done in the most appropriate setting. No different than like preparing hazardous drugs. So I'm going to pass this back to Karen to kind of finish up for us, but kind of wrap up about safe infusion practices.
How many people were here this morning at 7 o'clock? Great. So I like the way he talked about the four P's. And so when we look at this, I know it looks like we're being a bit schizophrenic here, but we're really not. Because the thing is that when we look at over here is the processes that we have to be considering. The inconsistencies within the organization are one of the processes that we need to be challenging, because it is a safety risk. And also, I think, just to reinforce what Maureen was saying, that we're making it too easy for our colleagues who are taking drugs to be able to access them. So from a patient safety perspective, and also to support our colleagues, this is an option for us to do. And then we can also look at, and also over here, and over here is our policies. So again, adopting the existing standards and guidelines. So look at them, and again, thinking about what best practice means. It's looking at the current standard, looking at your organization and the patient population that you serve. The patient populations that we see in downtown Toronto will be different where we're taking care of patients, or where we have patients in Etobicoke near Lakeshore, where they're, it's just a very different patient population, right? And so we need to be looking at how can we adopt those and integrate those practices. There's some that have been there since 2010, and they're not being integrated into practice. And why is that? So this is where we as clinicians can start to advocate for, because policy is not just for people in the C-suite, right? Nurses as professionals, we're to advocate for our patients, and advocacy is a key component of policy. So don't underestimate your influence. Okay. On the other side, this way, is really around the people. So we need to be educating our colleagues, and education was one of the things that came up very clearly in the Joint Commission survey, came up very clearly in the ISMP survey that they did, and also the recommendations for safe IV push medication practice. So we can never over-educate people on this, because again, just remember the stat that I talked about, 2/3 of the errors are because of injectable medications. So we can change that. And then the other one is the product. So from a product, about adopting products that increase patient safety. So whenever possible, and when I say product, the pharmacy is really critical here, in that whatever possible, they need to be preparing the medication for you to be able to administer. And this is another thing that, again, is a policy piece, and with the NAPRA guidelines coming in, it's going to be very easy for pharmacy, or there'll be a real push from pharmacy to put it back on the backs of nurses, which they've done in the past as well. And we can't let them do that, because that's their role, is to prepare medications in a controlled environment that reduces the patient's risk of contamination and infection, and also medication error. So this is where we can collaborate with them. And the other thing is some simple things like pre-printed labels. It makes your life easier, and it's also a safety piece. Okay, and it's also harder to, when you have a syringe that's full of opioids, it's not labeled, it's very easy to just kind of pick that up, stick it in your pocket, and away you go. Where if it's labeled, it's not that simple. So some of those things we need to think about. And so again, it's evidence-based change. It's around looking at pharmacy and nursing collaborating. We are the two most prominent professions within a hospital, or actually within a healthcare environment. And so we have opportunities to really improve medication initiatives and improve nursing practice, really. And also from a quality and risk perspective, these policies can really help to make a difference. So this is where we push up and pull down so that we can get things changed. I mentioned again before around IV push medication education. You have to have that consistency as far as how you're going to define it, and come up with standard recommendations for ordering and also administration. And ISMP, this guideline here is free to everyone, and it has some very solid recommendations that could easily be incorporated into your organization tomorrow. So, we talked about sacred cows. It's time that we acknowledge that some of them exist. Maureen talked about Lean Six Sigma, again, plan, do, study, act, making changes that are in the best interest of our patients. We have a duty to care, and part of that duty to care is knowing what is the right thing to do and how do we get that moved forward. So thank you very much for that. Time for Q&A. Do we have time for questions? Okay. Kathy, you have a question?
Yeah, hi.
Hi.
Just a comment, thank you. Mike. Just a comment, I don't know if the rest of you, we at Vancouver Coastal Health have just had a new PDTM created, and I'm not sure who was on the committee, but they are using the terminology IV direct. Mm-hmm. And I just, while you were talking, looked up a few of them, and it's quite interesting. They're telling that the drug needs to be diluted. Many of the drugs need to be diluted. And then they use terminology like give over 2 minutes, but a next one says give slowly over 2 minutes. Is 2 minutes not 2 minutes? I mean, one says give slowly, underlined, over 2 minutes. And the next one says give over 2 minutes.
Should we give quickly over 2 minutes?
Well, or slowly. Quickly over 2 minutes. 2 minutes is 2 minutes. I find it interesting, so just a comment, but IV direct seems to be the language that they're using.
Interesting. And none of the recommendations or guidelines that we looked at use that terminology.
No, that's a good one. And then
Yeah.
I think the other one that we found in some of the other books was dilution may be preferred.
Yes.
Preferred
Yes.
by who?
Yes.
Preferred why?
Yeah.
I think all of us like to think of evidence-based practice, and I myself like to see some evidence. And I took the time to go out and try to look to find some evidence. So morphine's a good example. It's a legacy drug. It has been approved by everybody long before people expected, RCTs and all this kind of evidence. So there are some people, though, who have studied morphine. And there is a very good study that was done where they looked at post-op patients, men who had bladder TURPs done, and women who had hysterectomies, and they came to the recovery room immediately after surgery, and they monitored their pain, and each person, their initial dose of pain medication was 7.5 milligrams of morphine IV push over less than 1 minute. And they all had wonderful improvement in their pain scores, and they had no change from their baseline vital signs. Blood pressure fine, respiratory rate fine, O2 sat fine. So that was like, wow. And if I would have expected derangements, I would have expected it in an immediate post-op who may still have anesthetic on board. So that was a really important study. And there's been some other smaller studies that have been done where there is a body of evidence being created now about some of these things. And I think we have to start saying, well, let's pull that evidence in. It's not going to go back up through Health Canada. It's not going to go back up through the FDA. But I think that's what evidence-based practice is about, is looking at all the different types of evidence that are available to us to help guide practice.
Pam, are we out of time? Okay. Thank you, everybody.
So thank you to Maureen and Karen. Next for CVA members will be the annual general meeting, so we invite all members who are part of CVA to stay for the annual meeting.